Dr. Pradeep, you can go ahead. Get started.
So I welcome all the respected seniors for the ICOG Academics and Perspectives webinar with Chhattisgarh Societies of Raipur, Durg, Bhilai and Bilaspur. And with the starting of the webinar, we'll start with the blessings of the divine for enlightening us with the knowledge.
मैम आवाज नहीं आ रही है वीडियो की.
Yeah, I think
Dr.
the audio is
Pradeep,
not
you
playing,
have
but
to
that's
share
okay. You can
again
go
with
ahead.
audio.
Okay, ma'am.
If it's not heard and it's not working, it's okay. We can proceed.
Okay, ma'am. So I'll start with the introduction of Dr. Pratik Tambe sir, who is a ART consultant and gynec
There's
endoscopic
no need to
surgeon.
introduce me. That's fine. It's okay. I'm going to give.
Okay, sir. Then should we directly go for the first talk, sir?
So I'll just welcome everybody. On behalf of ICOG, I'd like to express my gratitude to the epoxy office bearers, our president, Dr. Jaideep Tam, Secretary General, Dr. Madhuri Patel, the ICOG office bearers, our chairperson, Dr. Pani Putradawala, sir, who's going to join us very soon, Dr. Sheila Mane, who is our vice chair of ICOG, and Dr. Sarita Balera, secretary ICOG. We are also going to have the presence of Dr. Parag Biniwale, who is the chairperson-elect of ICOG, and he will be logging in soon. It's my pleasure and privilege to be the convener for this program, along with Dr. Charmila, who is the series convener for the ICOG Academics and Perspectives webinar. Today's program is in association with the three Chhattisgarh societies, Raipur, Durg, Bhilai, and Bilaspur. It gives me great pleasure to welcome the dignitaries, the presidents and secretaries of these societies, and they are going to be the chairpersons, and they are going to be here throughout this program. So thank you very much, all of you, for collaborating together and being with us. Without further ado, I will hand over back to Dr. Pradeep Kaur, who is the coordinator for today's program, requesting her to please introduce the first set of chairpersons, and then they can introduce the first speaker, Dr. Archana Desai.
Yes. So the chairpersons for the first topic are Dr. Tabassum Dalla Madam, who is Vice President Raipur Menopause Society and President of Raipur Obs and Gynae Society 22-24. She is Vice President IMA Raipur 2023 and Consultant Obstetrician and Gynecologist Director of Jubesta Hospital Raipur. I welcome you, Madam. And the second chairperson for the talk is Dr. S. Birthire Madam, who is Present Director of Birthire Nursing Home and Maternity Center, Champa. She is founder, member and President of Bilaspur Obs and Gynae Society for years 11 and 13 and Vice President and Secretary of IMA Janjgir, Champa. She is active member of Lioness Club for past 32 years and she's a very senior gynecologist of this region. I welcome you, Madam, and please introduce our speaker for this topic. That is the OB position in labor.
If they're not there, you can go ahead and introduce. Let's not stand
Okay. So the speaker of the topic is Dr. Archana Basir Madam, who is consultant obstetric and gynecologist and director at Akash Hospital, Indore. She was Vice President Foxy in 2020 and organizing secretary of AICOG 2021 Indore. She is fellow representative of AICC RCOG West Zone and Imaging Scientific Science Committee chair of SAFOG. I welcome you, ma'am. Please. Hello.
Thank you. I'm here.
Yes,
Can
ma'am.
I be allowed to share my screen?
Yes, ma'am. Your co-host, you can share.
Can you see my screen?
Yes, ma'am, but you're not full screen as yet.
I know I can't really manage.
You can just do slideshow from beginning at the top. Slideshow from beginning. Play from the start.
Not happening.
Doesn't matter. You can go ahead. We can see this.
I know you can see, but I'm not feeling good.
That's all right.
Normally you do it and it's not happening. Anyways, I think I can just do it like this a little bit bigger. Well,
Yeah.
thank you very much. And I would like to thank Dr. Pratik Tambe for giving me this opportunity and ICOG for giving opportunity and collaborating with all Chhattisgarh societies. And my regards to Dr. Sharmila, who is present here, and all the speakers and chairpersons. So my talk is occipital posterior position, delivery tips and tricks. I know good outcome in labor, you need power, passage, passenger, and a push. And the role of obstetrician is every labor is a challenge. And as an obstetrician, we always have a big responsibility to hand over a healthy baby to a happy, healthy mother. And it is important we constantly update ourselves with the basics also. So our goals and objectives, what is occipital posterior position and problems in occipital posterior position in labor, how to diagnose occipital posterior position, what is the mechanism of labor in occipital posterior position, how the delivery takes place in occipital posterior position, and take two work points. Let's just have a revision of what is position. Relation of denominator to quadrants of pelvis. Here is sacrum, here is the symphysis, and you divide it into four: left anterior, left posterior, right anterior, and right posterior. Anterior is towards the symphysis, and posterior is towards the sacrum. This is your left occipital transverse position. Like your occiput is in the transverse and on the left side, so that is left occipital transverse. This is right occipital posterior. This is pubic symphysis, this is sacrum, and occiput is in the posterior. This is right occipital posterior. If you look at the left occipital posterior, this is left occipital posterior position, and this is occipital posterior position. And this is how is the presentation in occipital posterior position. In occipital, this is right occipital anterior, this is left occipital anterior, and here I have put the pelvis right, left, and anterior and posterior. If you look here again, these are the different positions: left occipital anterior, right occipital anterior, occipital posterior, and occipital transverse. So we have to know the sutures when we are talking about the position. Right occipital posterior position. How do you define occipital posterior position? It is a vertex presentation with fetal back directed posteriorly so that occiput lies in one of the posterior quadrant. And what is the incidence of occipital posterior position? It is 10% at onset of labor. It can rotate to anterior position during labor. Right occipital posterior is 5 times more common than left occipital posterior because the left oblique diameter is reduced by the presence of sigmoid colon. And dextral rotation of uterus favors occipital posterior when spine is on the right side. So this is about the malposition, right occipital posterior position, and this is how the baby will be in the right occipital posterior position. What are the problems of the deflexed head? Occipital posterior position, deflexed head, larger presenting diameter, and all problems of ill-fitting presenting parts will be there. So if you look at the problems, normally we are taught that either labor begins with the pains or it begins with the spontaneous rupture of membrane. So whenever there is a malpositioning, the labor begins with spontaneous rupture of membrane rather than contractions. Labor is going to be prolonged. It may be a difficult labor. When it is a difficult and prolonged labor, mother might have sepsis. There can be trauma and atonic PPH and birth asphyxia. So how do you diagnose occipital posterior position? By history. Repeated, what I have observed in clinical practice, if a woman is repeatedly coming at terms with backache, increasing vaginal discharge, cervix is not dilating, and the presentation is invariably they have an occipito-posterior position, do a palpation, what is being taught to us, history, palpation, umbilical grip, the back is felt with difficulty in flank away from the midline. The anterior shoulder is at least 3 inches from the midline, and the limbs are easily felt near or on both sides of the midline. So these are the palpation tips. How do you diagnose occipito-posterior position? By first pelvic grip. Head is usually not engaged due to deflection, and the head is felt smaller as palpating fingers catch the bitemporal diameter instead of biparietal diameter. And second pelvic grip, the head is usually deflex. So this is how, this is the normal, when you palpate in the normal position, in the anterior position, you palpate a different diameter of the head. And when it is a malposition, you are palpating the different dimensions of the head. And you look here, the limbs are more easily felt and the back is difficult to be located in the as compared to the anterior position. Again, by the auscultation, FHS are heard in the flank away from the middle line. By vaginal examination, cervix is 2 to 3 centimeter dilated, not well applied. Presentation in clinic with false labor is more often in occipito-posterior position. What you need to do is keep a close watch on such pregnant women near term. What is the mechanism of labor? The head engages through right oblique diameter in ROP and left oblique diameter in LOP. The engaging transverse diameter of head is biparietal 9.5 centimeters. Anterior posterior diameter is either suboccipitofrontal 10 centimeter or occipitofrontal 11.5. In favorable cases, with the help of good uterine contractions, it results in good flexion of head, normal descent occur up to pelvic floor. Occiput rotates 3/8 of the circle, that is 135 degree anteriorly, to lie behind symphysis pubis. Shoulders rotate about 2/8 of circle to occupy oblique diameter. And rest of the mechanism is like that of right occipito anterior in ROP and left occipito anterior in LOP. So this is how it is going to be like that. Like it is your occipito posterior. When it rotates, the rotation happens in this direction and it will rotate with a good contraction. What happens in the unfavorable cases, which are 10%? Certain cases, occiput fails to rotate, deflection of head, the uterine contractions are weak, the sacrum is flat, prominent ischial spine, convergent side walls, weak pelvic floor muscles, or a big baby, or early drainage of liquor. What is the results in unfavorable cases? One of the following will occur. Long interval rotation, that is 3/8 circle, occurs in about 90% of cases and delivery is completed as in normal labor. Direct occipito-posterior phase 2 pubes occur in about 6% of cases. The head can be delivered spontaneously or by aid of outlet forceps. Episiotomy is done to avoid perineal laceration and deep transverse arrest in 1% and persistent occipito-posterior in 3%. What is the course of labor? Average duration of both first and second stage of labor is increased. In first stage, engagement is delayed, persistence of deflection of head, driving force transmitted through the fetal axis is not aligned with the axis of inlet. So what happens? Early rupture of membrane occurs, abnormal uterine contractions, and in the second stage, there is delay due to long interval rotation or malrotation with at times arrest of head. In third stage, there is increased incidence of postpartum hemorrhage and trauma to genital tract. So what are the tips for safe delivery in occipito-posterior position? Early diagnosis, strict vigilance with watchful expectancy, hoping for descent and anterior rotation of occiput, judicious and timely interference if needed, and early cesarean section if it is getting too prolonged. Have a partogram. The first stage is managed as in the normal case. Nothing can be done to correct the malposition or to influence the rotation of head at this stage. A partogram is done to monitor the uterine contraction, frequency, duration, and strength, fetal heart, dilatation of cervix, and documentation for future if there is any problem. What should be your course of action? If progressive cervical dilatation does not occur, augmentation with an oxytocin drip to be done. If it's still no progress obtained in a few hours, cesarean section is performed. Also, if there is a fetal distress, C-section is done. This is a deflexed head, like it's just like it's in the transverse position, it's not budging at all. So possibilities are in direct occipito-posterior position. There can be phase 2 pubes delivery, delivery by flexion, with that the uterine contractions and no contracted pelvis, but perineal lacerations are more liable to occur as the vulva is distended by the large occipitofrontal diameter 11.5 centimeter and perineum is overstretched by large occiput. So this is how it is going to be like. With an occipito-posterior, there is deflection of the baby's head, and so there is a larger diameter to stretch the vaginal entrance. And this is in the occipito anterior position. So how do you manage labor? First stage, exclude contracted pelvis, exclude presentation or prolapse of the card. Inertia and prolonged labor are expected, so oxytocin may be indicated unless there is a contraindication. Avoid doing ARM and monitor closely. Assisted vaginal delivery may be needed. Vacuum extraction, want to use forceps. Proper application as near as possible to the occiput will promote flexion of the head. Traction will guide the head into the pelvis till it meets the pelvic floor where it rotates. Manual perineal protection is always needed, and episiotomy is nearly always. Though we are talking about not an elective episiotomy in every labor, but in persistent occipito-posterior position, or to begin with it was a OP position, I think it is good to have a episiotomy. What are the alternative methods? Mul rotation followed by forceps, manual rotation, sorry, followed by forceps extraction, forceps rotation and extraction, and cesarean section. Operative vaginal delivery prerequisite. Safe operative vaginal delivery requires a careful assessment of clinical situation, clear communication with mother and relatives, and expertise in chosen procedure. Cesarean section, again, it may be difficult. C-section, emergency, when senior members are not around, usually happens. There can be a deep transverse arrest, persistent occipito-posterior position, and reverse rotation and arrest. So just brought one case for unexpected difficulty in case of POP position. This is Mrs. AMK, 27 years, 67 kg primary, conceived on subfertility treatment, uneventful antenatal period, spontaneous labor at term. She's progressing very well till 9 centimeters. Presentation, patient comes in on a Christmas day and with almost perfect condition for vaginal birth. What happens next? 1.5 hours, no descent, oxytocin 1 on flow, no place for rotation. Am I running over the time? Then I can cut down. And
No, ma'am,
fetal
you're perfectly fine. Please go ahead.
oxytocin on flow, no place for rotation as it's a deep transverse arrest, fetal bradycardia down to 80 beats per minute. Now, how we manage the situation? We decided to do C-section. There was an impacted head, which is the most common unexpected problem. Peritoneal incision has to be given higher up to avoid the bladder. Gentle pressure to widen the incision because it's a second stage C-section. If you use an undue pressure, then you might go from one uterine to another uterine. So pressure has to be very gentle. Shoulder, usually you will find at incision. There was thick meconium. Assistant at bottom and gently push the head towards incision side. What is my important point, which I always tell in my students also, not to push head before uterine incision, otherwise bladder will come in your incision. So first give your incision, then ask your assistant to push the head. And other techniques like your Patvardhan and other techniques may be needed. And final challenge is to suture the uterus, because it is like a uterus which has really worked hard to push the baby. Repeated vaginal examination, because we want to monitor the labor progress and we want to deliver the patient vaginally, and that leads to the ecchymosis and easily tearable uterus. So suturing is also has to be done very diligently, otherwise you end up in problems. So now tip for C-section, I've already said, and the most important thing is call for help. If you are alone with a deep transverse arrest, occipito-posterior position, call for help for a colleague or a senior or junior, whosoever is you are compatible with, call for help. Then this is a second case where multipara. Primi, yes, you know that there can be a problem. In multipara, there was a expect unexpected. This was a gravida 3, para 2, live 2, vaginal delivery, 3 kg babies, adequate pelvis, spontaneous labor, 5 centimeters. ARM was done, head engaged, good contraction per abdomen. Position could not be ascertained because she was little obese. Good contraction to begin with, no descent occurring and contractions fading. Caput developing, pitocin was started. Fetal distress, large baby, POP, failed rotation, and it was a large baby. So, I mean, what is important here that our concern is mother and baby options. Either you do normal physiological birth or operative vaginal delivery or perform emergency C-section. So I think what the points I want to bring is that you have to be very, very observant. You have to monitor your patient and mother and baby well. And the most important thing is a timely decision taken in time really helps you and your mother and the baby in the long run. And if you have to perform emergency C-section, you please call for the help. So from my side, take to work message is identify problem in time, use partogram to pick up the slow progress. First, support normal vaginal delivery, assess for trial of operative birth, train in instrumental delivery. It is never too late. If not appropriate, know how to perform a safe C-section in second stage of labor. So thank you very much for your patience listening.
Thank you, Dr. Archana Basil, ma'am. I think that was a crash course in a very important presentation, which we often ignore in labor. And I would request the two chairpersons, Dr. Tabassum Bella and Dr.
I'm
Sharat
really
Bhattacharya, to
sorry.
please give us your
I can
remarks.
do the slideshow. I'm feeling so bad. I can do
That's
occipital
fine.
posterior position, difficult C-section, but I can't do slideshow.
But we imagined everything, and it was a very nice presentation, ma'am. Thank you so much. We brushed up everything what we studied in our medical colleges, and now I think we are going to have some more practical tips and points. All the students would enjoy it a lot. I would say that what is your take on very deep engaged head and someone pushing from vagina up? The head has to be pushed up. Some people, they do that if the head is very much engaged inside, then there's a possibility that if you're not able to get it from up, somebody pushes it from down. So that is a way sometimes to
Yes,
take the head out.
there is nothing like a absolutely right or absolutely wrong. You are adrenaline rush is the person who is performing the delivery, and if you have to push the head, what I am telling is, do not ask to push it before your incision, because if you are pushing before your incision, because the bladder is also very, it's very difficult to
Distended,
catch with
yes.
the bladder. It is distended, and everything is like very much echymos and very much tired kind of a thing. So make your incision, then ask someone so you can put your fingers from above, and maybe your finger and your person who is pushing fingers meets, and then there will be a little air. All of us have experienced that little air goes in and it comes like a suction, it comes up. But don't push before incision.
Good point, ma'am. A well taken message from you for that.
Thank
So
you.
thank you so much.
Can we hear from Dr. Birthare as well, ma'am? Thank you so much for being here. It's lovely to see you in person.
Yeah, good evening to all. Thank you, Dr. Archana.
Thank
Very
you, Dr.
nice,
Birthare.
excellent talk, ma'am. And you explain each and everything very nicely.
Thank you,
So
ma'am.
nothing
Thank you
left,
for your patience.
nothing left. And congratulations. Thank you so much.
Thank you, ma'am. Thank you so much for your kind words and really patience listening.
Dr. Gavdeep, you can take over and thank
Yes,
the
sir.
chairperson of the previous session and introduce the next.
Thank you, ma'am. And with this, we move on to the next topic. That is the modern management of subchorionic hematoma. And the chairpersons for the session are Dr. Monica Pathak, madam, who is consultant and director of Sai Surushita Hospital. She is laparoscopic surgeon and a well-known gynecologist of Raipur. I welcome you, madam. And second chairperson is Dr. Sangeeta Sinha, madam, our own president of Bhilai Foxy Society. And she is director of the Srijan Bhilai Test Tube Center and ART consultant laparoscopic gynecologist. Welcome, ma'am.
Yeah, hi everyone. Hi Pratik sir and hi all.
And
Hello,
please,
sir.
ma'am.
Thank you so much, sir. Pratik Tambe, sir. Thank you so much. Greetings from Raipur Society. Thank you for involving our society in such a prestigious webinar, sir. We are honored.
And
So,
madam,
so for the next topic, we welcome our own Dr. Asa Jain, madam. She's name needs no introduction, but it's a formal introduction, ma'am. She's MD, DNB, MNMS, MBA, FICOG, FICMSH, and Kathak Vid also. Madam is the director of
Sangeeta,
SMSA.
please say whatever you want to say. We can
Fine,
stop
ma'am.
sharing this.
Okay. Ma'am Center is recognized for ultrasound training as well as colposcopy training. Her field of interest is saving the uterus, fetal medicine, obstetric and gynecological ultrasound, critical care, as well as we know her mainly for preventive oncology, colposcopy and all. So welcome, ma'am, and over to you for your talk.
Thank you so much, Sangeeta, Dr. Sangeeta. If I would be allowed to share my screen.
Sure, Pradeep.
Please go ahead.
Yeah, thank you. So I hope my Ganesh ji is feeling sleepy and his mouse is doing the work. I hope we are all awake who are listening. So thank you, Pratik sir, for having me here. Thank you, ICOG, Foxy, and Raipur, Bhilai, and Bilaspur societies for joining in this webinar. After a very scintillating lecture by Archana ma'am on a very, very practical topic, I go to the other extreme. It's part theoretical, and let me make a confession at the very beginning. The current management of subchorionic hematoma, there actually isn't anything, that I have to say right before I start with the lecture. Whatever you're doing is just symptomatic. So what is the definition? Subchorionic hematoma is the collection of blood between chorionic membrane and uterine wall, often seen in early pregnancy, and it is associated with adverse pregnancy outcomes if it is large and persists into the second trimester. So up to 25% are going to have subchorionic hemorrhage. If you do an ultrasound on 100% pregnant patients, you will see a subchorionic hematoma in up to 38% people. And out of those, 20% will lose the pregnancy. So what are we going to do? We have to understand the etiology and risk factors because we will not be able to treat everything. The etiopathogenesis includes poor placentation, immunological factors, structural abnormalities of the uterus, and one important thing is abnormal chromosomal configuration of the fetus. It can be associated with factors like a previous miscarriage, advanced maternal age, and assisted reproductive technology. So in up to 50% of cases, it is chromosomal anomaly that causes the threatened abortion, and we should be really careful what we are trying to prevent. It's diagnosed by the history where the patient comes with either pain or she comes with bleeding, or you actually do an ultrasound for anything, for confirmation of pregnancy, and you find that there is a subchorionic hematoma. So it shows a hypoechoic or anechoic area, which is adjacent to the gestational sac. And what is important here is that not all hematomas are the same. the size of the hematoma and the location of the hematoma affect the prognosis. So what are we going to do? We are going to look at the hematoma by ultrasound. It is visualized as a crescent-shaped echo-free area. The size is crucial in determining management and predicting outcomes. And ultrasound monitoring every 1 to 2 weeks is recommended until hematoma resolves. So when you write it, it looks easy, but you'll see that all hematomas have a different appearance. This is totally anechoic. Here you have it looking almost like the myometrium, difficult to diagnose. And here again, it's not very easy to see that it's there. So we have to understand that the diagnosis is the first part of it. It should be correctly diagnosed. And in this, in the simple ultrasound, taking the help of Doppler will guide you a lot because there will be no flow in the area of the hematoma, whereas there will be flow around the gestational sac. So we can diagnose the hematoma, we have to measure it, and then we have to grade it. If it involves less than 1/3 of the gestational sac, it's called a small hematoma. If it is 1/3 to 2/3, it's medium. And if it is more than 2/3 of the gestational sac, it is large. If the volume of clot is more than 15 ml, it correlates with higher risk of miscarriage, preterm birth, and placental complications. Because wherever there is a clot, that is the area of the placenta that will not be functioning properly. Increased risk of miscarriage, preterm birth, placental abruption, and fetal growth restriction in case the pregnancy proceeds. And if it presents after 12 weeks, it has worse outcomes than those that present earlier. So if it is a hematoma at 16 weeks, 18 weeks, it will have a worse prognosis. Now, how do you manage it? The management is focused on monitoring and, if necessary, addressing symptoms like bleeding or pain. There is no standardized therapy. Approaches may include expectant management, hormonal support, or immunotherapy. We are used to giving everything we have in our armamentarium. I have seen prescriptions with injectable progesterone, vaginal progesterone, oral progesterone, HCG, immunotherapy, along with bed rest and isoxaprine. Everything is given. But what is the standard? The standard is still not achieved. There are no clear guidelines about what you should be giving. Certain things are found useful, and that is what we will be discussing now. First thing is the hormonal support. Vaginal progesterone is often used to reduce miscarriage risk, especially in early subchorionic hemorrhage. Evidence on efficacy is mixed, but the support is used in high-risk patients, especially if there's a previous history of miscarriage. And dydrogesterone has a dual function, the progesterone and immunomodulatory function. And only dydrogesterone from the parent company studies are available, which show that it works. And the dose is 4 tablets stat, that means 40 milligram, followed by TID. Then we come to the additives, the nutritional and supplement support. A combination therapy with high molecular weight, hyaluronic acid, magnesium, vitamin B6, and vitamin D have shown to aid faster resorption. This is the study that you see. But the problem with this study is it's a study on a very small number of cases. It's 25 versus 31. And they found that when this addition was given, progesterone was given, and these tablets were given, and the resorption in the patients who received the nutritional therapy was faster and better. Immunotherapy. This is a retrospective study, and what it is telling you is it's in about 700 cases, but they were all cases of recurrent miscarriage. Now, in the women who had recurrent miscarriage and subchorionic hematoma, when immunotherapy was given, it reduces the rate of miscarriage. But here, the confounders are very many. And as per guidelines, immunotherapy has no role to play in subchorionic hematoma. Now, what about bed rest and activity modification? Bed rest is frequently advised, though evidence on its effectiveness is inconclusive. But if there is heavy bleeding, you can ask the patient to rest for a couple of days, and it may be beneficial for large hematomas or in cases with very significant bleeding. What about pregnancy complications management? If the patient has a subchorionic hematoma and she carries the pregnancy through, which will happen in 80% of cases, then you have to keep checking this patient for gestational hypertension, gestational diabetes, PROM, preterm labor, and regular follow-up with ultrasound to assess the size of the subchorionic hematoma and the impact it is having on pregnancy. Another aspect of this management is patient counseling. We need to educate the patients on potential outcomes, not always paint a very rosy picture ki sab theek ho jayega. You cannot say that, because 20% are going to lose the pregnancy. And you need to, if she is being hospitalized with something else, otherwise, if she's going home, we have to educate her about when she has to come back. If there is increased bleeding, if there is more pain, then we have to counsel her when she has to come back to the hospital. And psychological support for anxiety is also required. So you have to counsel her, you have to counsel her partner, and sometimes you also have to counsel the family members so that she doesn't get over tense. One thing is, don't paint a rosy picture all the time, because everything is not in your hands. Majority of small to medium SCHs resolve by second trimester, and the resolution is associated with a better pregnancy outcome. If the hematoma persists, then you need even closer monitoring. What about the adverse pregnancy outcomes? There is a high miscarriage rate and risk for preterm birth when the hematoma is large. So you need to have timely intervention if this occurs later in pregnancy. Then, depending on what facilities you have for preterm delivery and how young a child your nursery can look after, you need to plan early delivery if there is a large hematoma which is persisting and the baby is viable. What about ART? There is a higher incidence of SCH in ART pregnancies, especially if they are IVF pregnancies. And these cases, any pregnancy with ART needs additional surveillance to detect early and treat early. What are comparative outcomes of pregnancies when there is a hematoma versus no hematoma? SCH is associated with a higher risk of complications like gestational thrombocytopenia, placenta adhesion, preterm labor, FGR, and PIH. So there is an importance of distinguishing outcomes based on SCH size and patient risk factors. So it's not just the hematoma, but it definitely increases the chances. What is the long-term outcome for the offspring? No significant difference in physical development. Neurodevelopment requires further investigation, so we need to monitor these babies. What are the preventive recommendations for high-risk groups? Consider immunotherapy and nutritional support, regular ultrasound monitoring for early detection and management. We need large-scale studies on the effectiveness of IVIG, high molecular weight hyaluronic acid, and other therapies. And we also need to investigate the long-term developmental outcomes in children. So in summary, the incidence of SCH on average is about 25% and about 20% end in miscarriage. Taking a detailed history is very important. It is wise to locate the embryo or the fetus with heartbeat before you start any treatment. Progesterone, dydrogesterone is shown to be more effective. Bed rest has some positive effect, and vitamins, hemostats, etc. have a placebo effect. After 20 weeks, if pregnancy continues, SCH seems to have no effect on outcome. When a patient comes to you with subchorionic hemorrhage, you need to rule out violence, accident, domestic violence as DDs. You need to find out about it and be aware that that could also be a reason. Recent papers again suggest increased PIH and FGR in cases which had SCH. 50% of first trimester losses are due to chromosomal abnormality. This must be remembered while managing. Tender loving care and reassurance with correct information about possible outcomes will save a lot of heartache for the patient and her obstetrician. So SCH requires individualized management based on size, persistence, and patient history. Close monitoring and potential interventions can improve pregnancy outcomes. So we should be prompt, carefully monitor, diagnose. The treatment is patient-specific. Consider nutritional support and immunotherapy for high-risk cases. And if it is persistent, it is correlated with adverse outcomes. Early resolution improves prognosis. So what do we have? We have progesterone, we have nutritional therapy, bed rest, counseling, and that serial ultrasound. That's all we have for the management. Thank you very much for a patient listening. And if there are any questions, I'm open. Thank you.
Excellent, excellent presentation, ma'am. As usual, you're very to the point. Your talks are always to the point and very practical. And definitely, we do agree that it is basically only the symptomatic treatment is required. Patient counseling is the most important part of it. So we should spare time, counsel the patient and the relative. And definitely, I do agree that rosy picture should not be always posed. And definitely dydrogesterone and vaginal progesterone do have very important role. And the size and antenatal surveillance by repeated ultrasound is the key point for this. Excellent. Very nice presentation.
I have a question in the chat box by Dr. Shilpa Harne. So she has asked, what are the investigations that we have to do? So the first thing is to do the ultrasound. If she is a high-risk case, she would have been monitored. We need to see the volume of the bleeding. We also need to see if there are any coexistent risk factors, the viability of the fetus, and then take it from there.
Jan ma'am, it was very nice, short and sweet presentation. Lots of query were raised. Like hemostatic, there is one question in the chat box also. Hemostatic given or not given, and what is the dose? Number 1. Number 2 is what is the dose of hyaluronic acid? And number 3, the immunotherapy which we are using, and what is the dose?
The high molecular weight hyaluronic acid capsules for us are not available. It's a study that was done in a research setting with 150 milligram dose. Okay.
Okay. So what you are giving in your practice, or and
What
what
more
I
clinical
use
is something called as alpha lipoic acid, which we use in
alpha
fertility
lipoic
practice.
acid, ALA.
Okay, fine. So
100
what is the
It's
milligram
dose
not
of
very
that?
widely available and
100
it's quite
milligram
expensive,
TID.
but it's something which has been tested in multiple small studies. There are no large randomized controlled trials, obviously, because you can't have an RCT for a woman with subchorionic hemorrhage. You can't induce a subchorionic hemorrhage in a woman to
It's
study an
100
agent.
milligram OD.
Yeah.
100 milligram OD.
OD, but it's not
Alpha
available.
lipoic acid.
Okay, fine.
Alpha lipoic acid is available.
available,
Ala
yes.
capsule, it's available.
Yes, available. And tranexamic acid or ethyl in what dose? Or
I don't
everything
use.
should be started.
I don't use,
Don't
and I
use.
did not actually find any evidence for
Any result.
subchorionic hemorrhage that you should use
Fine.
it.
No, there
And
is a study on tranexamic acid for
Yeah.
subchorionic hemorrhage.
Yeah,
They
some
combine it with
small thing it
progesterones.
gets
There's
absorbed.
a
Yeah.
Russian study. It's a Russian study. They use tranexamic acid with the progesterone, and they say it has got a good benefit.
Yes.
Okay, and
Okay.
what is the dose, ma'am? Charmila, ma'am?
500
500.
milligram TDS it is.
TDS.
Like for
Fine.
this thing they give.
Fine. And the immunotherapy, what immunotherapy you people are using, like ma'am, Jan ma'am, Charmila ma'am?
No, immunotherapy, I don't think it's very useful
It's
for
very tricky, yeah.
No, you take it as a threatened miscarriage, and usually
Yeah.
progesterone is the one which you give,
Progesterone,
either
yes.
vaginal or dihydrogesterone. And
Yeah.
tranexamic acid is all investigational. It is not a recommendation anywhere. So recommendation is by RCOG and I think one more society has given if she's had a prior history of miscarriage and she bleeds in this pregnancy, in early pregnancy, she's got a subchorionic hemorrhage, you can consider giving vaginal progesterone according to RCOG. FIGO says you give it oral dihydrogesterone of 20 milligram daily. That is a recommendation by both societies, but that is with a prior history of miscarriage. For a sporadic threatened miscarriage, there's no recommendation at all. But we extrapolate that repeat miscarriage to this and give progesterones, that's all. But there is no recommendation for a sporadic subchorionic hemorrhage.
Okay, thank you, ma'am. Thanks,
Thank you very much, Dr. Asha Jain, Dr. Monica Pathak, Dr. Sangeeta Sinha. Thank you very much for being here, all of you. It's lovely to have so many senior and distinguished office bearers with us. I will hand over back to Dr. Pradeep to introduce the next set of chairpersons.
Our next topic is the to know your ICOG, and the chairpersons for this talk is Dr. Charmila Madam, who is Vice President FOXY 2024 and Vice President of Trichy Obs and Gynae Society. She is Chairperson Clinical Research Committee FOXY. She was Chairperson Clinical Research Committee FOXY 2016-2018. ICOG Governing Council member 2021 to 2025. She was National Coordinator, UNICEF FOXY PCA, MEDHA FOXY PG program and ISAR Gurukul program 2022-23. A series convener, ICOG Journal Club and ICOG Certificate Courses 2022 to 23. WHO Southeast Asia Region MDSR India member. President of Menstrual Hygiene Management Consortium 2018 to 2020, Secretary Justosis India Association and Academic Wing of Assisted Reproduction, Trichy, and member of PCOS Society of India. Thank you, ma'am. Welcome, madam.
Thank you, Dr. Pradeep.
Yes. And the next chairperson is Dr. Pratik Tambe, sir. Let me introduce you, sir, this time.
He's already been introduced earlier, so let us not waste time. Let us introduce the main speaker of the day, Dr. Parag Biniwale, Vice Chair-elect of ICOG. And first, when this entire series started, I spoke to Parag and said, we should take this to more societies, do it more regularly. So he himself said, why don't you do one program with the Chhattisgarh Society? So thank you very much, Parag sir, for giving me this opportunity. And he's here today in a totally different time zone from the other side of the world, from San Francisco actually, which shows his commitment to ICOG. I will request Chamila to please do the honors and introduce Sir formally.
I don't think Dr. Parag needs any introduction anywhere in FOXY. He's one of the best speakers in FOXY. He's a senior consultant from Pune. He's the chairperson-elect of ICOG 2025. And he's a president of, he was being the president of the Pune Society, vice chairperson of ICOG, president of the Menopause Society of Pune, and he is holding several positions in FOXY as well as ICOG. And this program is his brainchild. He wants every member of FOXY to know about ICOG and utilize the opportunities in ICOG. We are all examples of how well ICOG has trained us. Being governing council members for 2 terms, they have learned so much through ICOG. And Dr. Parag is the best person to tell you how all you can utilize your ICOG to better yourselves. Maybe request Dr. Parag to give his talk on Know Your ICOG.
Thank you, Charmila. Thank you, Pratik. I bring greetings from ICOG. It's very early in the morning. It's around 6 o'clock in the morning. But then when we decided this program, I didn't realize that there would be a day saving, and instead of 6:30, I have to be here in the program at 5:30 in the morning. But anyway, it's always a pleasure to be part of the ICOG activities. At the outset, let me thank the President Foxy, Dr. Jaideep Tak, Chairperson, Dr. Parul, Vice Chair Dr. Sheila Mane, and the Secretary Dr. Sarita Bhalerao who agreed to have this program. And I must appreciate all efforts put in by my two very, very enthusiastic governing council members, Charmila and Pratik, because this is the third of this program, and they have been the conveners. In fact, we have one more in Tamil Nadu societies next week. Thank you, all the Chhattisgarh societies. In fact, I visited all these three societies way back in 2010 when we conducted the assisted vaginal delivery workshop. So it's nice to connect again with all these three societies through this very, very simple program called Academics and Perspectives, because we thought that ICOG, which is the academic wing of Foxy, should reach out to members, and then members also should feel that they can become part of ICOG. And we have a perfect example here. Dr. Sharad Bethare, who's such a senior person, became a fellow of ICOG 2 weeks ago. Pratik and Charmila, both of you have witnessed this, and even at this seniority, she in fact opted to be a fellow of ICOG. So thank you, Dr. Birthare. You have set an example in front of so many of us, youngsters, I should say, as compared to you, who would like to become part of the ICOG. So in next 15 minutes, I thought I'll just talk about what ICOG is. Right. So ICOG, the Indian College of Obstetricians and Gynecologists, was founded way back in 1984. So it's a 40-year-old organization, and it is always considered to be the academic wing of Foxy. So currently we have over 2,400 fellows and around 182 members. The reason why ICOG was started, it was started with a vision to advance standard of care and improve quality of healthcare practices throughout India. And we always believe that we, our members, should have a safe, ethical OBGYN practice for the benefit of our women. And the aim and objectives of establishing the college was to promote training, research, and spread of knowledge in the field of gynecology, obstetrics, reproductive health, family welfare, and related areas. These are the chairpersons who have brought ICOG where it is today, and it is thanks to all of them we are trying a bit to take it ahead. This is the team of ICOG 2024, and I take over as the chairman in 2025 AICOG at Mumbai. I must appreciate all my governing council members, 25 of them, all senior people. Half of them are senior practitioners and half of them are senior professors in medical college who have contributed immensely to the working of the governing council of ICOG. Coming to the administrative activities. So the first thing that was started almost 12 years ago was the ICOG credit points. And we have to understand that these credit points are important, especially when you wish to become a fellow of ICOG and you do not have enough research publications to join the ICOG as a fellow. So who all can get it? All Foxy societies and all Foxy committees do get these points for their programs without any charges. Of course, all the state level organizations, all medical colleges, the other organizations like RCOG, FIGO, SAFOG, AOFOG do get ICOG credit points without any charges. Of course, the other organizations like ISAR, ISOPAB, etc. can avail this facility with a small payment. ICOG CMEs is something which are going on for last many years, and ICOG invites applications from Foxy societies. So all the three societies, if you are interested, do write to ICOG office, and we can certainly have these programs. We do conduct around 20 CMEs, and these CMEs focus on evidence-based medicine in different areas. And this is something which we've started to make sure that we improve our own clinical practice, and ultimately it is the patient care which will be benefited. There's a certain grant given by the ICOG, 25,000 for a 1-day CME and 50,000 for a 2-day CME. There is an application form which is available on the ICOG website, and you can certainly write to us, complete the formalities, and we will have ICOG CME at your place. ICOG training is something which is a very important aspect of ICOG, I should say. And we have ICOG training in reproductive medicine. We have almost 42 centers which are imparting the 6-month certificate courses, 28 centers imparting knowledge in gynecological endoscopy. If you look at the list, there are quite a few, even from Madhya Pradesh. I don't see any from Chhattisgarh. So any of you who qualifies to have this training at your place, please get in touch with the ICOG office. We do have training for vaginal surgery, critical care in obstetrics, and gynecological ultrasound. And of course, one of the most sought after areas nowadays is fetal medicine, where we have the 6-month courses. Last year, we ventured into a fellowship program. So there are quite a few centers who are going to train young postgraduates for a span of 1 year, and which is really important when we think of areas like reproductive medicine, where it is now governed by the ART law. The lecture series is something which is again interests a lot of people, and there are governing council members, Pratik, Seema, Poonam, Chinmay, who have worked very hard to make sure that the lectures reach out to all the candidates. The idea of starting the lecture series was to have a uniform theory training for all the candidates who are pursuing the 6-month certification courses, and now, of course, the 1-year fellowship courses. There is in fact exam conducted, so it's the candidates have case presentations which are assessed by our coordinators, and this is something which is important for them, especially when they appear for the exit exams for all these certification courses. Those who are not actually taking training, but the youngsters who are interested in joining these courses may do so. You can contact the ICOG office, and you can attend all these lectures against a small payment. And this is definitely an exhaustive program for training in that particular subspecialty. The ICOG and fellowship and membership is now available just at the click of your mouse, and these are the links which are there to for you to become members or fellows. Of course, there are certain criteria for membership, and you can attend the convocation. The next convocation will be during the 67th AICOG in Mumbai, but the application lines are currently closed for Mumbai, and now we will be opening the lines again shortly for the convocation during ICOG conference in Pune, which will be on the 1st March of 2025. So those who are interested, those who have missed applying, still have time till 31st of Jan to apply for fellowship of ICOG, and you can attend the convocation at ICOG conference in Pune. What are the criteria of becoming a fellow? So Mindwell fellowship is meant for senior people, those who have a postgraduate qualification for 10 years, they have to be members for 5 years. If they do not have 3 publications, we do accept 100 ICOG credit points over 3 years, and it is really easy to get ICOG credit points. attendance of 2 Foxy sponsored conferences in last 10 years is important. And now there are so many Foxy conferences which are taking place all across the country. If you have a faculty certificate of at least 2 conferences, or if you have presented papers as first author in 2 conferences by Foxy, FIGO, AOFOG, or any national level conference, we do accept it. And there's a small payment which is associated with this. And younger members who have a postgraduate degree for 3 years and who are members of Foxy can opt for a membership of ICOG, that is MICOG. We are still working on how to convert this MICOG into FICOG, and maybe by the next year end, we would have a mechanism to do that. The Foxy ICOG Dr. C.L. Jhaveri Symposium is something which is a highlight of AICOG. It is conducted on the second day, and it is named after the founder chairman, late Dr. C.L. Jhaveri. We select 5 speakers based on their contribution to the subject, contribution to the ICOG, and they are given a certificate at the end of this program. The ICOG Dr. C.S. Don oration, late Dr. Don was the second chairperson of ICOG and 23rd president of Foxy. This is an oration which is organized every year at the ICOG conference, and it is delivered by the immediate past chairperson of ICOG. ICOG Dr. Usha Saraiya oration, this was again started by Dr. Usha Saraiya, who was the chairperson of ICOG and past president of Foxy. This is in subject of gynecological oncology. So again, there is a process of application. You will receive an email from ICOG office, and then you need to apply with the topic and what exactly you wish to speak on that particular topic. So the topics are scrutinized by the office bearers and of course by Dr. Usha Saraiya, and we select one who delivers the ICOG Dr. Usha Saraiya oration for that particular year. This is the oration which was started in 2018 by past chairperson of ICOG, Professor Krishnendu Gupta. So it is called ICOG Professor Krishnendu Gupta Conference Oration, and it is delivered by any person who has contributed extensively to women's health. And of course, this is a part of the ICOG conference. ICOG RRR oration, which was started just last year, and this is thanks to Dr. Lakshmi Srikhande and the organizing team of RRR ICOG conference at Nagpur, who have given a generous donation, and this oration is delivered by the sitting chairperson during the ICOG conference. ICOG is known for its web-based activities, so all activities like ICOG PG Gurukul, ICOG Jogi, Research Methodology and Journal Club. We have webinars on family planning, masterclass, which is once a month or twice a month activity. Foxy ICOG PG Clinic is something which is very, very popular and which is with the focus to train postgraduate students as per the norms of NMC. This year, Dr. Parul started ICOG, the case I shall never forget, and this is something which was really interesting, where we hear our seniors talk about management of difficult clinical cases. The ICOG certificate courses for 3 days, which take place every month, and these are 3-day courses on a particular subject. And of course, you do get a certificate after you attend all 3 days and attend the 3 post-test and secure more than 50% marks. And ICOG New Frontiers in OBGYN is something which is again an activity of ICOG done every alternate month. This is something for the teachers who are here in the audience today. There are 2 ICOG traveling fellowships which are funded by ICOG. So we expect a professor to visit any of the Foxy societies or a medical college who set an application to ICOG, and we expect them to spend about 2 or 3 days in these places. The travel is taken care of by ICOG, and of course, we expect the societies to look after the hospitality of the visiting professor. For youngsters, the ICOG MQR Pharma Travel Award. This is meant for youngsters less than 40, and here grant is given to these candidates who wish to train for about 2 to 4 weeks anywhere in India. Little information about ICOG election. So we have elections every year. So this year, in the year 2025, we will be having election for the post of secretary and governing council, because these are the people who are in office for 2 years. And then every alternate year, we have the vice chairperson elections. What are the benefits of becoming ICOG member and fellow? Please note that only fellows of ICOGs are eligible to start new ICOG certification courses. Members of fellows of ICOG can apply for ICOG MQR Traveling Award. They do get a chance to be invited as speaker in ICOG CMEs, Dr. C.L. Javeri Symposium at the AICOG, and Dr. Usha Saraiya Oration. The visiting professorship is only again for ICOG fellows for visiting any of the medical colleges or societies, and one can certainly become faculty in various ICOG web-based activities which are ongoing this year. So if you have any queries, please do not hesitate to write to the ICOG office, or even we are just a phone call away. You can always get in touch with me or Pratik or Charmila, and we will do whatever best we can to help you to work for ICOG. And at the end, I take this opportunity to invite you all to Pune. This is the 10th ICOG annual conference on updates in OBGYN, meant for generalists, the general OBGYNs. We don't intend to touch upon the hi-fi subjects, but it will be very, very basic subject which are important in day-to-day practice. So please block the dates, and very soon you will all receive e-brochure and do join in at Pune with us. So thank you very much, and I look forward to seeing all of you in various ICOG activities. Thank you very much.
Thank you, Parag. That was very, very clear. I hope the members who are attending today, please spread the message in your societies and ask the youngsters to get those credit points and join ICOG's fellows. That will be, you will learn so much from this academic activities. Every month, something new keeps on happening. Thank you, Dr. Parag, for joining us from US. It's I know it's so difficult, but thank you so much for that commitment.
My
Pratik?
pleasure. My pleasure.
Thank you, Bharat, for being here despite the daylight savings time and the aftermath of the Trump victory. I'm sure it's a very turbulent time there.
It's very cool out here, and it's very cold out here. You can see my costumes.
Dr. Pradeep, would you like to do the honors? And thank
Yeah,
the
and
chairperson.
just a special mention, Pradeep, you've done a good job. You know, being a coordinator of any of the programs is not easy, because you need to get in touch with everybody and ask for their CVs and keep on pestering them to join on time. So very well done. And thank you all the chairpersons, all the president and secretaries of societies in Chhattisgarh for joining with us today.
Thank you so much.
Any
So
doubts?
second
Anybody would like
present-
to have some clarifications?
I think Dr. Monica has applied for the ICOG fellowship. She has just messaged me. So once her application goes through, probably either in AICOG Mumbai or at the ICOG annual conference in Pune, one of the two you will receive. If you have the choice, the office will be in touch with you.
Yeah,
was
normally the
nice.
procedure that we follow is once we receive an online application. Now it is really easy. You know, previously we used to send a big bunch of certificates and the form to the office, but now it is just a click away, and this is all thanks to the COVID times, because during COVID times we switched to the online application method, and you just have to attach all the necessary documents. You need not attach any of the physical copies, but you have to have all the certificates, which even after ICOG courses, we do send ICOG from the ICOG office a certificate which states about the ICOG points. So you just have to attach all these things, and it is really easy. Once we receive an application, it is scrutinized by the office staff and then confirmed by the ICOG chairman and secretary. And once we confirm it, you will receive an email from the office. So if there are
So I
any
had also
queries,
applied for the
Happy
same.
to share
Great.
one thing, sir. I'd like to share one thing. Since last 6 years, Raipur Society, every month we are having one or the other CME, either online or offline. And every last 6 months, every CME, we are getting credit points. And happy to share that last year, the last one which we went, almost 11 to 15 members of Raipur Society, they got fellowship, FICOG. So thanks to all of you, ma'am. You all people have keep guiding us. And it was Asha Jain madam who had started first, and then we followed, and now we are here today. Thank you so much.
I would like to thank Parag sir, who told me about those ICOG points, and on a phone call, he would grant the points. So I think, sir, all this Raipur Society has joined in as ICOG members is all thanks to you. And you're being, so kind to pick the phone and always respond. So thank you so much.
Pleasure.
Thank you, Charmila ma'am.
Asha hates it if
Thank
you
you,
don't
Pratik
answer her
sir.
call. Asha hates it if you don't answer her call.
Actually, everybody hates it. Nobody says it.
That's true. That's true.
That's all.
Thank you, Asha.
If there
Thank
is
you.
nothing further to add, then at the end of the day, I'd like to present the common vote of thanks as the convener. I'd like to express my gratitude to the FOXI President, Dr. Jaideep Tam, Secretary General, Dr. Madhuri Patel, the ICOG office bearers, Dr. Parul Kotadawala, who is our chairperson, Dr. Sheila Manu, Vice Chair, Secretary, Dr. Sarita Bhagera, our chairperson-elect, Dr. Parag Biniwale Esper himself. I'd like to express my gratitude to the other two speakers, Dr. Archana Baser, who is our past Vice President of FOXI, Dr. Asha Jain, who is a newly elected Chairperson of FOXI. Congratulations again. To all the chairpersons, Dr. Tabassum Dalla, who is the President of Raipur, Dr. Sharad Bilthare, a very senior and legendary respected figure from Chhattisgarh, who, as Parag said, recently received the FICOG herself. Dr. Monica Pathak, the tireless President of Raipur Society, thank you so much for all your help and coordination in organizing this entire program. And she was the one who recommended Dr. Pradeep Kaur, who's done a fantastic job as the coordinator today. Thank you again to the ICOG backend team. And finally, thank you, Parag, for giving me this opportunity to be convener, along with Dr. Charmila, who's the sales convener.
Thank you, sir. It's
Thank
nice.
you.
Thank you.
I must
Dr. Tamre.
acknowledge presence of Dr. Shobha Gudi, who is also a very,
Yeah,
very
Shobha was
enthusiastic member.
Yes.
So next job for you, Pratik, is to tie up with the Maharashtra societies. Next week, we have Charmila taking us to Tamil Nadu again. And Shobha, for you and Vidya, it is the Karnataka societies
Parag.
we have to
We are
cover
there.
soon. We'll try to cover all these societies before we are,
You take over.
inducted as ICOG
Yes.
2025 team.
Correct.
So Maharashtra will go
There are
according to the
22
amount
societies
zones
in
there, because
Karnataka.
there are so many.
We'll
districts.
have two programs. We'll have two programs.
Yeah.
We'll do that.
Okay.
Thank you.
I'll talk
Thank
to
you
you
so much.
once, Harita,
Yeah,
so
yeah.
that we'll
Sure,
plan.
Yes, sir.
Okay.
Safe trip back home.
Thank you.
Parag, you
Thank
survived
you.
the election in America?
Yeah,
We
yeah,
just were talking
it's
about
He's very
here.
hardly
cool.
2 minutes back.
Very cool.
I'm surviving the cold here. That's it.
No, it was as expected, no? It was as expected, I think.
So people were expecting the result.
A bit sad.
Chalo. Okay.
Okay.
Have a good evening,
Yeah,
all of you.
Yes, yes.
Thank you,
Bye,
sir.
everybody.
Have a
Thank
nice
you
time,
again.
Parag.
Good
Enjoy.
night.
Yes, thank you.
You can stop the
Yes, yes.
recording now. Finally.
Enjoy your holiday.
Yes.
Not a holiday, in brackets.